mental health needs in special populations. The elderly/geriatric population. Common mental disorders among the aging population include depression, anxiety, dementia-related behavior disorders, and psychosis. Untreated mental illness in geriatrics result in higher emergency department use, increased burden on caregivers and long-term care facilities, loss of independence requiring institutionalization, and that can in turn raise Medicaid and Medicare spending. Assessment screening of elderly and geriatric population include tools such as the Patient Health Questionnaire, which screens, diagnoses, and monitors the severity of depression. Also, the Generalized Anxiety Disorder Scale, which screens and measures severity of generalized anxiety disorder and useful for panic, social anxiety, and PTSD. The Work and Social Adjustment Scale also measures functional impairment due to a mental health condition. The Montreal Cognitive Assessment Screening screens for mild cognitive impairment and dementia. The Mini Mental State Examination, widely used tool to screen for cognitive impairment and monitor progression of dementia. Treatment plans for elderly and geriatric population. Pharmacological interventions include SSRIs, SNRIs. They really try to avoid the use of TCS due to the high risk of anticholinergic effects. The last resort is to use antipsychotics. Really great collaboration is through primary care providers, social work, psychiatry, and sometimes neurology needs to be brought on board. Some psychotherapy options for this population are cognitive behavioral therapy. The core principle for this is that thoughts, feelings, and behaviors are interconnected, and when they identify and restructure the disordered thinking patterns, patients can change emotional responses and behaviors. Let's see here. IPT, which is interpersonal therapy. The core principle here is mental health symptoms that are closely tied to relationships and social roles. And by improving the interpersonal functioning, the symptoms actually decrease. The last one we're going to talk about here is problem-solving therapy. The core principle is for psychological distress that can be reduced by improving problem-solving skills and coping mechanisms. This focuses on practical strategies rather than deep exploration of thoughts and feelings. The next population is the perinatal/lactation population. This is a period in the time of pregnancy for women through 12 months postpartum. Common disorders that can be diagnosed are depression, anxiety, and very rarely, but it can happen, is postpartum psychosis. The development of the perinatal depression and postpartum blues is currently unknown, but it is likely multifactorial. The assessment screening tools for this are the Edinburgh Postnatal Depression Scale. It's a screening tool that's designed to identify women at risk of perinatal and postpartum depression. Again, we see the Patient Health Questionnaire, which helps screen, diagnose, and monitor the severity of depression. And then the Diagnostic and Statistical Manual of Mental Disorders, and this is specific to major depressive disorder, but this one is for the peripartum onset specifier. So basically, a patient has to have 5 depressive symptoms for greater than 2 weeks, and the onset is during pregnancy or within 4 weeks postpartum. And then lastly, we have the Generalized Anxiety Disorder Scale, which again screens and measures severity of generalized anxiety disorder, and it's also useful for panic, social anxiety, and PTSD. Treatment plan for the perinatal/lactation population. For antidepressants, the first line would be the SSRIs. So these do cross the placenta and into breast milk. You can use SNRIs, but something you want to do is monitor the blood pressure, because that can elevate the blood pressure. You can use CCA, but again, they do have the anticholinergic effect. Antipsychotics can be used short term. However, we always have to remember that that will be exposed through breast milk. The collaboration for this patient would include the patient's obstetrician, the pediatrician of the infant, a lactation consultant, a pharmacist, psychiatry, and sometimes social work too. Some psychotherapies that we mentioned previously, but those also can be important for these patients, is IPT, the interpersonal therapy, the cognitive behavioral therapy. Also, group therapy and peer support is really important. A lot of new moms have new mom groups or first-time mom groups, and sometimes patients dealing with postpartum depression have specific groups to that they can just talk with other patients dealing with the same things. The important thing for these patients is that you always want to remember to balance the maternal benefit versus the infant exposure risk. Our next population is the pediatric/adolescent population. So mental health disorders are among the most common health issues in youth. Common disorders include depression, anxiety, ADHD, and other behavioral and conduct disorders. So important to remember is that early treatment can reduce costs and improve academic outcome. The pediatric adolescent screening tools, there are quite a few that we've seen in previous slides, but these are more centered to the pediatric population. For instance, the patient health questionnaire, this one is, it screens depressive symptoms in adolescents ages 11 to 17, so it's more specific to the adolescent population. The Center for Epidemiologic Studies Depression Scale for Children, also known as the DC, is a depression scale for children ages 6 to 17. The screen for child anxiety-related emotional disorders, it's also called SCARED. It screens for generalized anxiety, separation anxiety, panic, and social anxiety. The Generalized Anxiety Disorder 7, this one is the same anxiety disorder assessment, but it's adapted for adolescents. The Vanderbilt ADHD Diagnostic Rating Scales. This assesses ADHD as well as oppositional defiant disorder and conduct disorder. Connor's 3 rating scales. This measures inattention, hyperactivity, learning, and behavioral concerns. The Pediatric Symptom Checklist 17, it's also called the PSC 17, is a parent-completed screening for psychosocial problems. The Child Behavior Checklist, also known as the CBCL, is a parent report for ages 6 to 18, and it measures emotional and behavioral problems. One of the most significant ones I'm going to mention, which is the Columbia Suicide Severity Rating Scale, which, also you'll hear it used as the CSSRS tool. It's a tool that can be used throughout any of these patient populations, and it's one of the most important ones. This screens for suicidal ideation and behaviors. like I said, it's not just for adolescents. It can be used for the geriatric population, for the perinatal population, the pediatric population, and then the next couple of populations that I'll be talking about here shortly. To move on, the Modified Checklist for Autism in Toddlers, also called the MCHAT-R, is a parent questionnaire for toddlers being evaluated for autism. The Autism Diagnostic Observation Schedule, or the ADOS-2, is an observational assessment for autism. And then the last one is called the CRAFFT screening tool. And this screens adolescents that are at high risk for alcohol and drug use. The pediatric/adolescent treatment plan, some pharmacological treatments, things such as antidepressants. You can use SSRIs, SNRIs to treat anxiety and depression. A lot of times they use stimulants to treat ADHD. There's also medications that are non-stimulants that can be used. Antipsychotics can be used for severe mood or behavioral disorders, but that's kind of like a last line resort. The collaborative care between the pediatrician, psychiatry, school counselor, teacher, and family. Everyone needs to be on the same page when treating the pediatric population. Things that we mentioned before, CBT, DBT, which is another type of cognitive behavioral therapy. It was initially developed to treat borderline personality disorder, but it's used in many different conditions. It's basically the idea of balancing acceptance and change in treatment. Some things to note when starting any kind of pharmacotherapy, it's always important to start with a low dose and then increase as needed. Another side notes to make is making sure that you're checking weights for children that are on stimulants, and then you always want to assess for aberrancy or misuse on those as well. But evidence-based therapies for managing prevalent mental health conditions in adolescents include both psychosocial and psychopharmacological approaches. So it's important to include both of those. So the next population is the LGBTQ population. This population, they face increased risk for depression, anxiety, substance abuse, and suicidal ideation, primarily due to the stigma and discrimination. They are at a higher rate of suicidality in this community. They're also at an increased rate of using tobacco, alcohol, and drugs. Untreated mental health of this population can lead to an increase of emergency services and crisis intervention services. Some assessment and screening tools for this population include some of the tools that I've mentioned previously, like the patient health questionnaire, the generalized anxiety disorder. We talked about the Columbia Suicide Severity Rating Scale. A few other ones are the Kessler Psychological Distress Scale. This measures nonspecific psychological distress. There's also the PTSD checklist for the DSM-5, screens for trauma-related symptoms. This would be relevant because of the higher rates of violence and discrimination among this population. The Alcohol Use Disorder Identification Test is also known as the AUDIT. It screens for any problematic alcohol use. The Drug Abuse Screening Test, also known as the DAST-10, it identifies any drug use problems. We did mention the CRAFFT screening tool, which is geared more towards the adolescent population. Another the DSM-5 criteria for gender dysphoria. This is very popular in this population. It assesses the distress related to gender incongruence. There's also the Gender Minority Stress and Resilience Scale. This is used in research and clinical side to assess any stigma, rejection, resilience, and identity affirmation. Some things to consider when doing these assessment and screening tools is to always use inclusive language, always ensure confidentiality and privacy, and most importantly, we want to be respectful to these patients. The treatment plan for this patient population is similar to previous treatment plans. Antidepressants such as SSRIs to treat depression, anxiety, and the minority stress-related disorders. You can also use SNRIs. Antipsychotics can be used for the severe mood psychotic disorder, mood stabilizers for bipolar or emotional dysregulation. Some psychotherapies that are used along with the CBT and the DBT we talked about before. Affirmative therapy is something that helps acknowledge and validate the individual's identity. It addresses the stigma. The trauma-focused therapy is especially important for those with histories of rejection, bullying, and violence. Important things for these patients is group therapy and peer support groups. I think the collaborative care here is the primary care provider, psychiatry, possible endocrinology if they're going through gender-affirming procedures or medications, pharmacy, including any LGBTQ centers, families, important, school counselors if they're adolescent patients, and social work. The immigrant and migrant worker population, they often face mental health vulnerabilities due to language barriers, cultural adjustment, discrimination, and unstable work conditions. They often don't get the mental health care they need because of the cultural systemic obstacles, and this can place heavy social and financial strain on families and the healthcare system. Common mental health disorders among this population include depression, anxiety, PTSD, and then adjustment disorders. Assessment screening tools for this population include a few of the tools I previously mentioned, like the PHQ-9, the GAD-7, the CSSRS. There's also the Kessler Psychological Distress Scale, and it measures overall distress. The Harvard Trauma Questionnaires, HTQ, it assesses trauma exposure and PTSD symptoms. The Hopkins Symptom Checklist 2.5 screens for depression and anxiety, and it's used a lot in cultural groups. The PTSD checklist for the DSM-5, it measures the PTSD symptoms, and it's useful for the migrant populations with histories of violence or war or displacement. The cultural formation interview, the DSM-5, it's a structured interview, and it basically explores the cultural identity and stressors, supports, and it helps avoid misdiagnosis due to cultural differences. The acculturative stress scales, they assess stress linked to adapting to a new culture, language barriers, and discrimination. Other tools that you can use for this patient population are the audit for the alcohol misuse, the DAS-10 for drug-related problems, and again, the CRAFFT for adolescent drug use. It's always important to remember to use a valid translation tool and make sure you know the appropriate literacy level of the patient. The treatment plan for the immigrant / migrant worker includes Some of the same treatments as far as pharmacology goes, the antidepressants related to depression, anxiety, and trauma-related disorders, those can be treated with SSRIs. NRIs can also be used again. Both of these medications can also be used to treat PTSD and severe anxiety in this patient population. Antipsychotics can be used for severe psychosis and mood instability. It's important to collaborate care between the primary care provider, psychiatry, social work, pharmacists, interpreter services is important. Psychotherapy for this patient would include trauma-focused CBT, so it's effective for PTSD and displaced populations. Another form of CBT is the culturally adapted CBT/IPT. It incorporates the cultural values of that patient and includes the migration-related stress. Again, group therapy is important, peer support groups, family therapy, and then making sure that we're going through the psychoeducation with the patient in their native language. The care for these patients must account for barriers unique to migrant populations, things such as mobility, language, financial stress, and trauma exposure. The most effective approach for this population integrates affordable medication, culturally adapted psychotherapy, and then community-based support. Stress